moment to get ready. And all right, well, I think we'll start with just a very brief round of introductions. So we're going to start with our wonderful student presenters. If you just want to say your name, the university you're with, and the profession that you're studying. And we'll start with you, and then we'll introduce the judges in the same way. So I'll start. Why don't we start with Lynette?
Okay. I'm going to apologize in advance. I have a little bit of laryngitis. So if you cannot hear me, please let me know. My name is Lynette Waddell. I attend the University of Minnesota. I am at I'm taking the master's program as a dental hygienist, and I am licensed as a dental hygienist.
Great. How about Priya?
I'm Priya Perikarpan, and I'm with U of M Twin Cities, and I study pharmacy.
Great. And Lamia?
Hi, my name is Lamia. I currently attend H.E. Still University in Missouri, and I'm a second-year dental student.
Great. And Madeline?
Hi, my name is Madeline Nones. I attend the University of Minnesota, and I'm in my final year of my MPH in epidemiology.
And I see your coach, Todd? Or James?
Yes. Yeah, first name Todd, last name James.
Yeah.
I'm a physician for older adults, and I'm at University of California, San Francisco.
Great. Well, welcome all of you. And we'll start with our judges. How about if we start with John?
So I'm John Morley. I'm a geriatrician at St. Louis University. I started out my faculty position at the University of Minnesota as an endocrinologist. That was before any of you were born. That most probably includes the judges as well.
Welcome, John. And how about Jim? Go next.
Hi, everybody. Jim Pacala. I'm a geriatrician at the University of Minnesota.
And how about Joe?
Hi, everyone. I'm Joe Gogler. I'm a professor in the School of Public Health at the University of Minnesota.
Great. And Marla?
Marla Bergwager. I'm a faculty in the School of Social Work at St. Louis University, and I direct the Geriatric Education Center in the medical school.
Great. And Max?
Max Zubatsky. I'm program director of medical family therapy in St. Louis University, and also an alum of University of Minnesota's MFT program.
Great. And I'm Chris Talley. I'm in the School of Nursing at the University of Minnesota, and I'm a geriatric nurse practitioner as well. And just so you know, we have Sarah Engstrom on. She's our technical support person, so we're welcome to have her. And just so you know, we are recording the session. And with that, I will let the students have the floor.
All right, so I'm going to be the person presenting. So I'm going to go ahead and share my screen. All right, so can everybody see the presentation?
Yes, we can.
Okay, perfect.
Put it on slide mode. You've got the stuff on the side as well.
Oh, yes, I'm going to put it in present mode. So I guess I will have my teammates just tell me when to advance the slide. All right.
Okay, so, actually. Okay, sorry, technical difficulties. So the patient that we are going to be working with is named Camila Lopez. And in this presentation, we're going to summarize background about the patient as well as her concerns. We're going to discuss various patient-centered goals and include how various healthcare professionals can and should work together to provide the best possible care for her. Next slide.
Hi, we would like to introduce our patient, Camila Lopez. Ms. Lopez is a 75-year-old widowed Latina female. She speaks and writes in Spanish with limited English knowledge. She is undocumented. Ms. Lopez lives in an agriculture community close to her son. The closest access to care is 25 minutes away and is a federally qualified health center. She has limited her access to family and friends because of the illness SARS-CoV-2, commonly known as COVID-19. Her core values are her family, independence, and has worked as a part-time cleaner. Ms. Lopez's preference is not to go in for medical treatment unless prompted by family members. She has lingering effects of COVID-19, healthcare barriers, including language and financial. She has not visited her son or daughter and grandchildren based on fear of giving them COVID-19, which she had 3 months ago. Her symptoms are fatigue, headaches, body aches, weaknesses, cognition, forgetfulness, bad breath, metal taste, which may all be considered part of long COVID, the long-term effects of having COVID-19. Next.
So based on the provided medical history and lab values for Ms. Lopez, these are the current medical conditions that we determined. Of note, her existing diagnoses for type 2 diabetes and hypertension do appear to be uncontrolled. Some of her long-term COVID complications include brain fog, fatigue, loss of taste and smell, shortness of breath. Though we have anemia listed on here, it's not an official diagnosis and would require further evaluation by the medical team. There may also be some multifactorial geriatric symptoms related to aging that are occurring that put Ms. Lopez below baseline functional status. And this could be the slower gait, weakness, and mobility limitations, and these should also be further evaluated. Next slide.
All right, so now we're going to discuss the family dynamics a little bit. So the patient, Ms. Lopez, moved to the United States about 5 years ago. She had been living in Mexico with her husband, who unfortunately passed away from a heart attack. After his passing, Ms. Lopez's family recommended she move to the United States to be closer with her immediate family members. She currently lives in a small, rural town near her son, Mateo. Mateo works in a meat processing facility and was deemed an essential worker during the pandemic. This means that he had to continue working at the facility and had a higher risk of contracting COVID-19. He feels guilty about the transmission of COVID-19 to his mother, which resulted from his place of work. Mateo's wife, Amelia, works part-time at a restaurant and has a relatively close relationship with Ms. Lopez. She is available to assist with Ms. Lopez's health when Amelia isn't at work. Additionally, Amelia and Mateo have 3 grandchildren who Ms. Lopez loves dearly. Prior to getting COVID-19, Ms. Lopez spent time cooking for her grandchildren and helped to care for them when both parents were away. In addition to Mateo, Ms. Lopez also has a daughter who works as a registered nurse. Unfortunately, she lives 3 hours away. She also is married and has 2 children. However, Ms. Lopez hasn't spent much time with the family after contracting COVID-19. She misses them and really hopes that her healthcare intervention will assist in removing the barriers that are currently keeping her from quality family time. Now I'm going to move on to talking a little bit about COVID-19 in immigrant populations. The COVID-19 pandemic has not affected all individuals equally, and our patient, Ms. Lopez, was no exception to these inequalities. We are all too aware of the spread of misinformation and disinformation around both the virus and the COVID-19 vaccine. Unfortunately, misinformation has spread within non-English speaking populations where there is less access to healthcare and correction for this misinformation. Inadequate healthcare access and stigmatization around immigration status also create barriers both to vaccination and proper treatment of COVID-19. As a result, unequal transmission of the virus has persisted throughout the pandemic, and the Latinx population has experienced a disproportionate number of COVID-19 infections and also hospitalizations. This is further compounded by socioeconomic factors, which place a disproportionate number of Latinx individuals below the poverty line and working as essential workers. Of course, minority individuals face stigma in healthcare facilities, and they aren't always provided the best healthcare for their illnesses. However, in regard to the COVID-19 pandemic, factors outside of just hospital bias play a larger role in health disparities for the Latinx community. These individuals often present to the hospital at a later stage due to inadequate access to preventative care. As a result, Latinx individuals in some areas of the country are more likely to be hospitalized and more likely to die from COVID-19 compared to their white counterparts. Luckily, Ms. Lopez did not need to be hospitalized for her COVID-19 infection. However, she still didn't receive the care that she needed, and she is still struggling with lingering COVID-19 symptoms. Going forward with Ms. Lopez's care, an interprofessional team can help to mitigate different forms of systemic racism. For example, the use of an interpreter or a Spanish-speaking social worker can help to overcome the language barrier and ensure patient needs are met. Also, including community health workers on the care team can ensure that community resources are utilized that account for cultural differences in care between white and Latinx populations. And they'll also be more familiar with how to overcome financial barriers faced by immigrant communities.
So there are 4 patient-centered goals we would like to focus on when it comes to taking care of Ms. Lopez. These include reducing her fatigue, getting her back to work, seeing her family once again, as well as finding joy in daily activities, which is very difficult from her lingering effects of COVID-19 that we touched on. When discussing patient-centered goals, it's really important to remain ethical and focus on what the patient's desires and goals are. So we will briefly go into each goal and discuss how we, as various health care professionals, will work together to complete each task. Next slide.
So our first goal was to reduce fatigue, and our team seeks to do this with a multifaceted approach. The social worker, who is bilingual and also immigrant focused, will act as the care team manager and help Ms. Lopez navigate access to healthcare and also financial resources. Currently, Ms. Lopez does not have a primary care provider, but we would like to get her set up with one, or at least get her set up with a doctor at the community health clinic to help work with the pharmacy team to optimize her medications and monitor her conditions, as well as managing her conditions. Also, her medical primary care team can help assess her long-term COVID symptoms, as well as monitor her geriatric syndromes and general aging processes in general. The medicine team would also check her eyes for retinopathy, which can be associated with type 2 diabetics, and making sure her vision is okay will help improve safety and reduce curve fall risk. It would be important to provide patient education regarding her treatments and conditions so that Ms. Lopez can better understand how some of these changes can help her, even though they may seem like a burden. After initiating treatment, it will be important to follow up with Ms. Lopez. This is where the community healthcare worker and also her family can really be a lot of help. The community healthcare worker can provide at-home visits to ensure medication adherence and also help fill her pill boxes to improve safety. Her family can help coordinate appointments and help her stay on track with her plan of care. Both can help with home monitoring of her conditions so that Ms. Lopez doesn't have to go into the clinic to have routine measurements such as blood pressure, glucose, and cholesterol. Furthermore, a lot of these visits with her providers at the clinic can be conducted via telehealth if possible, and this would also help improve convenience for Ms. Lopez. Next slide, please. In order to reduce Ms. Lopez's fatigue, we will use a medication therapy management pharmacist working with her doctor to help optimize her medications. Some suggestions we have are adding medications to better control her hypertension, hyperlipidemia, and diabetes. We would work with her primary care provider to evaluate her potential anemia using additional tests. If deemed necessary, we would then add an iron supplement, which could potentially help reduce her anemia, which is often a source of fatigue. These medications would be dispensed at the community health clinic using the same sliding scale agreement that Ms. Lopez currently uses. The pharmacist can help educate on the importance of taking medications as directed and could coordinate with the community health care worker to help fill pill boxes and also make a pill calendar with examples of each pill to help reduce potential medication errors. So these changes to her medications do not all have to occur at once and can be implemented gradually to allow time to build trust with Ms. Lopez and also have time for education. In fact, they should be implemented gradually to also minimize side effects, such as potential postural hypertension, which she may already be experiencing a little bit of. By making these changes, we hope to improve Ms. Lopez's overall health and quality of life by addressing the conditions which are likely contributing to her fatigue. Next slide, please.
So our second patient-centered goal is helping Ms. Lopez get back to work. So to start with, the social worker can help and focus on finding healthcare and financial resources. He or she can aid in finding an occupational therapist who Ms. Lopez feels comfortable with and can learn from. Due to her fatigue, it was found that completing daily activities have been very difficult for her, as well as took much longer than before. So in that case, the occupational therapist will work with her and her family to complete daily activities quickly and give her the energy to complete her job. The community health worker should be present to support Ms. Lopez and monitor her progress over time due to tracking purposes. It is also imperative that the community health worker can educate Ms. Lopez on how she's improving and help her in any way to help her understand anything that she may not understand. The support from Ms. Lopez's family is also very crucial to help her getting her back to work. Creating the discussion with her family on how to coordinate transportation or how to aid in daily activities can help her enjoy going back to work and give her the energy that she needs to complete these tasks. So all of these professions coming together to help Ms. Lopez work will help her feel more financially stable and less lonely, since she will be able to interact with her Spanish-speaking coworkers once again. Next slide.
As part of goal 3, for Ms. Lopez to see her grandchildren, son, daughter, and coworkers, whom she considers like sisters, it is essential to identify the barrier she is implementing. Ms. Lopez's belief is that she will give them COVID-19. As part of understanding the Latino culture, an instrument was developed called the Simpatia scale. The Simpatia scale is a measurement that captures the tendency to prefer and create social interactions characterized by warmth and emotional positivity, while also avoiding conflict and/or negativity. This addresses Ms. Lopez's belief and concern that she will infect her family and friends with COVID-19. Ms. Lopez may not want to burden her family with her past illnesses or inconvenience her family. Conversations with Ms. Lopez's family are an essential part of the patient-centered care goals. Using motivational interviewing with Ms. Lopez and her family members will address their beliefs about COVID-19 and the vaccines. The community health worker will help implement family gatherings, which may involve cooking and meal preparation to help build the bonding relationships again and provide meals for Ms. Lopez and the families. Ms. Lopez and her family also need to understand the significance of her taking her medication and the positive effects of her health because of this. This, with the other patient-centered care, will enable her to see her grandchildren and provide child care once again. Education and family involvement will be ongoing for Ms. Lopez to return to work and see her family. Next slide.
The last and final goal that we have is for Ms. Lopez to once again find joy in daily life. Now, while we firmly believe in respecting Ms. Lopez's opinion toward her own health, we are also hoping to guide her toward making an educated decision on a COVID-19 vaccination. Going forward, this vaccine could remove roadblocks, preventing Ms. Lopez from finding joy in her daily activities. As Ms. Lopez travels to more public places, she is at risk of contracting COVID-19 again. She's also afraid of transmitting the virus to her family, and this could be avoided in the future if she does get vaccinated. We are hoping that Ms. Lopez's social worker, who is also the case manager, can build trust with Ms. Lopez in order to navigate the misinformation that Ms. Lopez has heard regarding the vaccine. The social worker can also help Ms. Lopez access other social services that can provide financial assistance as Ms. Lopez regains her strength and prepares to go back to work. This includes programs such as EBT, or electronic benefit transfer, which provides a monthly stipend that individuals can use to spend on fresh fruits and vegetables, which will be really important for Ms. Lopez as she starts cooking again. A therapist can also help to ease Ms. Lopez's opinion toward the COVID-19 vaccine, and the therapist can provide emotional support for the depressive symptoms Ms. Lopez has been feeling toward her recent life. Ms. Lopez's medications will boost her overall livelihood, making it easier for her to carry out the activities she enjoys. A dietitian will assist in meal planning. These planned meals will aim to be both nutritious and easy to follow so that Ms. Lopez feels capable of cooking for her family, which she misses dearly. While Ms. Lopez is actively working to resume her daily activities, a community health worker can provide additional support by being present at the home to assist Ms. Lopez if she feels overwhelmed by any of the changes in her routine. In time, Ms. Lopez will be able to carry out these activities unassisted, and the community health worker will be needed less often or possibly only by phone. Lastly, Ms. Lopez's family will be essential in this goal because they will provide emotional and physical support and remind Ms. Lopez of her joy for cooking and other activities.
So since we have discussed patient-centered goals, I will briefly touch on a future goal for Ms. Lopez, which is providing dental care. So as you can see, her concerns include swollen and bleeding gums, mobility of her teeth, spaces between her teeth, as well as halitosis. So a social worker can work with Ms. Lopez and her family to find a bilingual dentist who she feels comfortable with and can help her with her discomfort and concerns. A dentist will work with Ms. Lopez on creating a proper dental plan that fits her schedule and her wishes. It's important to note that since she is diabetic, she does have a higher caries risk and can take longer to recover from periodontal issues that she may have. This is why it's very important to educate her on her oral hygiene habits to help her with her overall health. This includes teaching her how to brush her teeth correctly, how to floss, and what types of food to ingest. So her diet may improve as well through this education. As her oral cavity heals, Ms. Lopez will understand how to better manage her health and feel more confident in her smile as time passes. Next slide.
Now, this is a slide that will discuss briefly the family's role in the care team. Amelia is going to be Ms. Lopez's main support in this care team because her work schedule allows her to support Ms. Lopez and be present at home along with the care team. Mateo is also essential because he lives nearby and he also can provide social support by being there at the house. Additionally, he might be able to provide some connections to health insurance through his work. However, that would have to be assessed going forward. Ms. Lopez's daughter is also a really important lifeline, although we do have to keep in mind that she does live far away. However, she can be available by phone and will help as support as Ms. Lopez is starting her new routine with her medications. She can remind her when to take her medications and also assist and support around other general good behaviors. Lastly, we have Ms. Lopez's grandchildren. As Ms. Lopez's energy is restored, her grandchildren can provide social support and also support in doing new physical activities. Previously, she loved cooking for her grandchildren, and her grandchildren can provide support as she begins that activity and once again finds joy in daily activities.
So we have mentioned the various interprofessional roles, but this chart shows just how much they overlap. The different professionals can communicate with each other using an electronic health record system, which allows documentation from all the different professionals to be visible by everyone. However, this would typically just work if they're all part of the same system, but if this is not possible, they can also use other secure forms of communication such as paging and secure email. Her care team can also have vocational huddle for care conference calls, which are just updates to give quick updates from each of their different perspectives on Ms. Lopez's progress. Logistically, this may be hard to include everyone on these calls, but whenever they can occur, they would be beneficial. Our care plan focuses on the role of the social worker and the community healthcare worker because they are essential in addressing Ms. Lopez's barriers to healthcare access and are most feasible at this time. Because Ms. Lopez lives relatively far from the clinic, focusing on other means of healthcare is important as she cannot always go to the clinic for all of her health needs. By addressing these patient-centered goals, we hope to improve the outcomes and quality of life for Ms. Lopez. Next slide, please. Lynette, you're muted.
Okay, thank you. Our interprofessional team included pharmacy, public health with a background nutritionist, masters of dental hygiene student, and a dental student. A shot Tummers, and Nordegraf address the need to identify gaps between interprofessionals for success. The first is called professional perspectives. This type of gap addresses professional views on the best way to treat the patient. Each member of our team learned about each other's professions, professional values, and norms. They were considered for each option regarding the plan of care for patient-centered care. Each member brought forth strengths that helped the success of our team. The second gap is bridging social community, understanding each team member's personality and communication preference. We addressed communication in our first meeting. Our personality differences were to our advantage in both the academic and working knowledge experience. The third gap is the communication division. Understanding each profession's verbiage was identified and clarified if any language barriers existed. And lastly, the task division gap. To address this gap, Ms. Priya captained our team to help facilitate meetings. Each member was engaged in discussions during our sessions. We use GroupMe, Zoom, and email to engage as a whole collaborative team. Overall, our experience reinforces that interprofessional teams should be implemented and utilized to provide patient-centered care to the best of each profession. Interprofessional interaction is a vital part of the academic environment, and each of us recognizes the significance of this in our future careers. We would like to thank the judges, our coach, Dr. Todd James, for his knowledge and guidance as part of our team. Thank the Health Resources and Service Administration of the U.S. Department of Health and Human Services, Geriatrics Workforce Enhancement Program, Otto Bremer Trust, and the University of Minnesota Office of Academic Clinical Affairs. Thank you.
And this is just our references that we utilize. And this is actually the last slide. So I guess I'm not sure at this point, should I exit out of this and then stop sharing my screen?
Sure, why don't you do that? So, well, at this time, I'm going to open the floor for judges to ask any questions they may have of the team members.
You know, I read a really interesting article yesterday. It was by Terry Fulmer. I believe she's the CEO now of John A. Hartford Foundation. John A. Hartford Foundation has been funding really critical work in how we can advance healthcare for older people. It's a great article. It just came out a few months ago in Health Affairs. It's called Actualizing Healthcare for Older People. And they make around 5 or 6 different recommendations. I don't expect you have read this, of course. I'm not trying to, this isn't a gotcha question. But one of the things I think was really interesting in the article was the need to incorporate public health perspectives and approaches when addressing and improving healthcare for older people. And in particular, a social determinants of health framework should be applied. And when we talk about social determinants of health, I think probably all of you are familiar. It's basically, you know, where we live, you know, where we work, where we play, how that influences our health as we age. And so thinking of it from that perspective, what would be other potential resources you could leverage to help improve Miss Lopez or Mrs. Lopez's care? It's Mrs. Lopez, right? That's the person.
Yes.
Yeah. Okay. I want to make sure. Okay. So again, like from that perspective, what else would you do beyond the interprofessional care approach?
Yeah, I can chime in quickly here. And I am also a public health student,
right.
And I am minoring in health equity. So I do spend a lot of time focused on community health. And so outside of just an interprofessional care team, when we're looking at social determinants, something that means a lot to me is really policy and looking at how, I mean, even within the interprofessional care team, how are those individual members thinking about influencing policy? And then the organizations that they work for, how are those organizations thinking about influencing policy? Because I think really advancing conditions for individuals that are underserved currently, I think a lot of that comes down to policy, which makes it really difficult to change, but also really crucial. So I'll let my other team members chime in here.
One other thing that we were researching is each county has a lot of resources for older adults. And this might just be senior centers or access to transportation through Metro Mobility or Meals on Wheels programs. And I think this is where the social worker can come in really handy because they have a better awareness of the resources that are available. So I think just exploring the local resources using that social worker would be one really good step.
Remember, loneliness and social isolation is a definite social determinant of health. I mean, we know from research the effects of loneliness on subsequent health outcomes. I mean, that's one thing that struck me in reading this case, and that came out a few times. I'll leave it to the other judges to ask questions.
I just want to add to that. I think
Yeah.
that's one thing as providers is that we're really seeing now is the depression and the mental health from COVID. So I think we can't really make light of that and the loneliness that has really affected everyone. So if we can try to build like the family relationships again and separate that isolation, but still finding something that's positive and how we can do that as our profession, each of our professions. That's all I want to add.
So I noticed that when you had your healthcare providers, you didn't think us physicians were useful. You didn't put us on your list. So that worries me a little bit because the whole role of interprofessional people is to communicate to the physician and improve his ability or her ability to function better. So it worried me a little bit. And then when I looked at what you did with the medicines, you put her on metformin, which is wonderful, but you left her on glipizide, which in old people losing weight is a reasonable way to get hypoglycemia. And as she lived alone, you would like to get her off that if possible. I also most probably would not have put her on amlodipine, which causes depression in many older people. And most probably,
I knew you were gonna.
I'm sorry, Jim.
I go, there goes Morley.
You guys did a wonderful job, you know.
You
And
folks
as
don't
an
realize
interprofessional team, you did a really good job. But you have to recognize deep down that there is a small role for physicians who know something about old people. This means that the social worker has to go find a physician who knows something about old people because we're a dying breed. I mean, there are half as many geriatricians practicing today as when I wrote the first geriatric boards in 1988, and we've lost 50% of the people who qualified in the interim without adding people. So I think recognizing there may be a role for older people and physician roles, but you did a great job pulling the rest of the stuff together. So I'm not holding it against you. I'm just hoping that as you go out there, you'll realize that even if the physician yells at you, treats you badly, does all the things that most physicians do, none of the good things, just the bad things. It's up to you to train the physician. That's where I learned most of my geriatrics was from the interprofessional team telling me what to do. And I think it's important that you realize this is a big role that you guys will have. And you're welcome to complain and tell me I'm wrong, okay?
So to clarify, John, I mean, you're recommending that, let's say a primary care provider, someone similar, could be effectively integrated into this team, not necessarily that they find a geriatrician. Because I would argue, the latter is you know, unrealistic.
You need, in her case, she needs a primary care physician to carry on with some of the stuff. The interprofessional health team group, which is the rest of them, should also be able to tell when she needs something more than a primary care physician. I'm not certain that she did need anybody more than that, but she did need somebody to do that.
Well, I'm going to jump in here because about 2/3 of the way through, they did talk about the importance of setting her up with somebody in primary care. That was on one of the
No,
slides.
I realize that, Jim. It's just that on their list of the people to look after her, they took us out. They had a list of.
Well, I saw pharmacy and medicine together, but I certainly.
Much as I love my pharmacists, I think that there are times when they don't do as well as me, and there are times when I do a little better than they. No, I mean, I'm just making the point because, to me, you guys are the future of old people care. It's really good old people care comes from the interprofessional team, but the interprofessional team needs to know also how to get the right changes for medicine out of the physicians. I mean, if I was one of you and the physician had told me not to stop the glipizide, I'd say, well, you don't mind if she dies from low blood sugar, or what are we going to do to protect her? It's just the sort of things that I think are useful. And I mean, you did a great job, so you must understand I'm nitpicking because there's nowhere else to go. I mean, I think overall the presentation was superb, but I do think learning how to work with physicians, which is most probably the hardest thing in the United States for physicians to do. Almost everywhere else in the world, the average physician knows how to use an interprofessional team, at least in Europe and Australia and Hong Kong and Singapore and all the other places I've been. But in the States, we do a terrible job teaching physicians how to be good physicians. So this is not a negative for you. It's telling you you've got to be a little more aware that physicians aren't always as good as you would like them to do. And I know Jim's a superb physician, so I have to be careful what I say, but realistically, there are a lot of physicians who don't know what to do with old people. That's all I was trying to say.
Yeah.
Is that fair, Jim?
Yep. Do we have more time, Chris?
Yeah, we have about 6 more minutes. So
okay,
if
good.
you have a question, Jim.
Well, I got a comment and a couple of questions. First of all, I thought you folks did a fantastic job. I think the focusing the case on using CHWs, community health worker, and care manager was really brilliant. And to me, that was sort of the main emphasis of this patient's complex needs. And so the way you hammered that in, I thought was really spot on. And that does address to a significant degree, not completely, but Joe's discussion about the social drivers of health. And, Lynette and Lamia with the goals, starting with the values and the goals, really, really excellent stuff. I loved the family diagram. And there were some other really, really high points during your presentation. I was interested in Madeline's discussion about COVID inequities and then how that could be perhaps rectified somewhat by using interpreters and cultural brokers. Madeline, how much do you know about interpreters and the different types of interpreters out there? And what I'm speaking about is with COVID these days, much of the interpreting is done over the telephone. So you can do, many times I'll walk into a room and there will be a phone sitting there and there's an interpreter on the phone. Or when you're working with video, there's an interpreter working, you have to patch in the interpreter from one location and the patient from another, and you've got to be in a third location in video. It can be awfully complicated. So I don't know if you thought about that. Did you folks think about how the interpreter would be provided? Would that be a remote, an in-person? Did you have any discussion about that?
I think that, and I just want to make sure that everyone can hear me because my screen's kind of frozen.
No,
Can people
you're
hear
good.
me?
You're coming
Okay.
in good.
Okay, perfect. I think our thought around that was really to focus again on the social worker as being a bilingual social worker and having them be present at a lot of these meetings to translate, because what we really wanted to emphasize was having a consistent translate or a consistent interpreter, if that was possible, in order to build sort of a trusting relationship with Ms. Lopez so that she could better explain her healthcare needs.
Thanks so much for that. And then I'm gonna dip back into the Priya. I'm warning you. I'm gonna dip back into the medicine waters here. I thought that the slide talking about her medications was quite good. I would have loved to have seen an analysis of not only their potential positive effects, but how each of them could also potentially contribute or harm her goals of care. And so that'd be something that I would encourage you to do. You know, the risk-benefit equation for old people in general, the benefit goes up with many medications with age, and the risks go up faster than the benefits with age. And so you've got to weigh more the risks of medications as people age than you do when you're taking care of younger folks. So, you know, the atorvastatin, you would have to weigh out its potential to cause more fatigue or muscle aches in her. And you know, that was a big goal for her, was to feel better. The blood pressure medicines could potentially cause her secretions to dry up. That can make her oral health worse. And so, you know, you'd want to, you know, and iron could affect constipation and perhaps her nutrition. So anyway, you've got to really think about not just the positive stuff, which we tend to focus on, I think, sometimes too much, and look also at the potential drawbacks of the medications. But really great stuff, folks, and I congratulate you.
Well, we have 1 minute left. Max or Marla, do you have any quick questions or?
I have one question. You'll make it quick because we have a minute left. If someone could speak to, what do you think the most important strategy would be in building trust with her and her family?
Well, I think the most important strategy would just be focusing on what is important to her, telling her that these are the conditions that she has and how she needs to fix them, maybe listening to her point of view and seeing how we can help her achieve her goals instead of her helping us achieve our goals for her.
Okay, good. You made it quick. Thank you. And you did a great job, all of you.
Thank you.
That was my question as well. So perfect timing. But great job, by the way, too. Wonderful. And I will give a lot of praise that not having a mental health professional on your team or from a family perspective, really hitting that on a extended family level and where they need to really integrate was good. So same question, Marla, on the trust and buy-in, but that was really impressive.
Yeah, I love the inclusion of the therapist. That was one of the later slides on the care plan. I thought that was terrific.
Great. Well, I'm going to take 1 extra minute and I'm going to give you an easy question, but could you tell me, like, what's one thing you learned about another profession that either surprised you or you didn't know about the way they either approached care or came up with solutions?
I can take this one. For me, it was a community health worker. I really didn't know much about the roles of a community health worker or how they can help Ms. Lopez. But after conversing with my teammates, I was really pleasantly surprised on just how much they can do and how important they are for this specific case and for many others as well. So that was definitely the biggest thing that I learned through this process. Yeah.
I'm just going to add a little note to that. I think too, for all of us, For me, I have clinical experience, but I think it's being open to understanding that there is different ways to look at it and each case. And I think that there is respect from each individual that we showed as a team, that you can understand, talk through what ideas fit best for this patient and not just be focused on ours, because as Lamia and I are both in the dental profession, of course we want to, dental, but that's not the patient's first goal. And so I think we can really focus on this patient. And we did that as a team. That's our focus.
Great. All right. Well, thank you, U of M team. You did a wonderful job. And Teresa, you'll have to let me know what the logistics are here for the next step.
Sure. So for the U of M team, what's going to happen next is you'll jump off, and then I will email you tomorrow to let you know the results of this competition. As you know, U of M team, you already get a certain amount of prizes for your participation in the competition. But we're so proud of you for doing this, and we'll be in touch more about, there's an article coming out with your names in it and all the other details. But for now, you and your coach are welcome to jump off, and then the judges are going to be doing their notations right now of their reflections on this, and then we'll finish up scoring later tonight. So thank you all. And good night. We'll see you guys later. We're keeping the judges on.
Stay if you want. You
Bye.
don't have to.
Nope. Students
Todd
go.
can stay if you want.
Hi, thank you very
Oh,
much.
Todd, yes.
Thank you.
Thank you.
Thank you.
Bye.
Bye.